Are we
All
ready?
right, and welcome. Yes, welcome to the PC 730 AIM game presentation for Saturday, May 27th. It's good to have you all here.
Hi, everybody. So I just wanted to give you a few words of how this works and hopefully relay a little bit of anxiety. Oh, Casey, do we have you?
Yes, I'm here.
Can you? There you are. And Caitlin, can we see your pretty face besides your mustache? Caitlin?
I can see her. I know that sometimes.
Okay, so as long as you can see her. Okay, yeah. All right. I just got it. So welcome, everybody. And I want you to all just take a deep breath. This is not to be a stressful event. This is our third touchstone with you to help you, to just give you another chance for us to help you with your measures and kind of getting your head around how this is going to go. So this is not a quiz. This is not a, you're graded really on participation and just trying to make this work and help everybody else. So it's both for us to help you and to have you help everybody else, because one of the pieces that we're trying to do is get you also proficient and feeling more comfortable with being in the role of advising everybody. So other people that as you finish this, you are going to be doing that. So that's what we're trying to work on. So the general plan of how this will go is we'll have each of you do your PowerPoint or Prezi. We're going to time it so that it is 5 minutes or less. And we just want you to do a professional presentation. You're going to just present what you have. It is not expected to be perfect. As I said, this is your third touch with us so that we can help you through this. And then after everyone is gone, we'll go back and sort of dissect them and ask questions. And those of you who do things really well can help present to those who aren't doing so well, vice versa, because usually everybody has an area that they're good at or strong at, and other people need help. Okay, are there any questions before I start? No? Okay. I would ask you to have a piece of paper and pencil. That's such an old word. To have some writing ability next to you. I'm just getting my timer on so that, Nisa, we just have to time people and I just have to.
Is it just me, or I can't hear anything? Anybody else are getting feedback from Dr. Butler?
I don't hear anything either.
Okay, good. Just make sure I wasn't the only one.
Go out and come back in.
Okay.
Yeah, I don't hear her either, but let's give her a second, see if her internet will pop back up, especially since she's the one timing. I can set a timer and we could get started, but she probably, let's see.
Hello.
Can you see me now? Hear me now?
Okay, we can hear you, but can't see you.
Yeah, I can hear you.
Yeah.
Can you see me?
Yes.
Yes.
I can see you.
Yes. Sorry about that. I do have no idea what happened, but keep your chat boxes open so that we can see it. God, my internet's doing wacky things. Nisa, you still there?
Yes. Yes, I'm here.
I can't see you. Okay. All right. So did you guys hear what I said? We're going to do our PowerPoints, and then after that, we'll go through everything. Yes.
Right.
Okay. I have Nisa, anything else that I've forgotten?
Looks good to me. Are you ready to time, or do you want me to do the timing?
Well, I'm doing it also, just sometimes I forget. All right, who wants to go first? Takers?
I can go.
All right, Ann, you're up.
Okay. So let's see. I need to screen share with you all.
Yeah. Do you remember how to do that?
I think so. Let's see here.
Could you remind us just in case?
Mm-hmm. If you
Yeah.
put your cursor on the screen, you're going to come up with, I think you people are all in front. Oh, over on the left, the little green arrow that says screen share. So just if you scroll, you'll see all those things on the left, and the green arrow says screen share. You want to do the entire screen and share to everybody. So you won't be able to see us, but we will be able to see you.
Okay.
And do you all want actually, I'm not going to do anything because it's just 5 minutes.
Okay, so can you see my screen okay?
I can.
Okay, wonderful.
You tell me when you're going to start and I'll start the timer.
Okay, all right, I am ready to start.
Okay, you're on.
Okay, my name is Ann Schaefer, and the title of my project is Improving the Efficacy of Depression Screening and Follow-Up Using SBIRT at a Multicultural FQHC. Harrisonburg Community Health Center is a federally qualified health center. We expect to see 35,000 patient visits this year, and about 65% of our patients do not speak English as their primary language. So my aim is to increase the efficacy of depression screening through a brief intervention and referral to treatment in more than 50% of HCHC clients ages 12 and older by September 15th, 2017. The big picture problem is that the economic burden of depression in the US is very expensive and estimated at $210 billion annually. Worldwide, we know that depression is the leading cause of disability, and yet depression often goes undiagnosed and untreated, even more so for minorities, immigrants, and refugees. And we also know that the rate of depression is higher in people with comorbid conditions such as asthma and diabetes. The rationale is that HCHC chart audits have indicated that we are screening about 48% of our clients, but only 20% of those have a documented plan of care or evidence of successful clinic follow-up. Furthermore, surveys and discussion with staff indicated there's a lack of knowledge about the rationale for screening and the best practices for follow-up. There's some frustration and confusion about how to document in the EHR, and we are underutilizing our in-house behavioral health services. The benefits of this project, it will increase team engagement, hopefully not only with depression screening, but with the concept of team-based chronic disease management generally. We hope to also increase the efficacy of depression screening and follow-up for patients, resulting in better management of their depression, a greater understanding of their plan of care, and improved utilization of behavioral health with a decreased no-show rate for follow-ups. And this should also bring us into greater compliance with UDS tracking metrics for depression for our center. So I know this is kind of a complicated slide, but this is my measures. I'm going to go ramp by ramp. For the teamwork ramp, A, my outcome is to increase team scores on a modified Huddle evaluation tool. And the process for that is we're going to increase the number of staff engaged in training and competency building. For the B ramp, patient engagement, the outcome is to increase patient understanding of their care plan. And the process for that is to utilize a brief intervention shared decision-making tool with our positive PHQ-9 clients. Our C ramp, our two process ramps, the first one, C, is for screening. The outcome is to increase the percentage of patients being screened for depression overall. And the process there is twofold. We're going to do better pre-visit planning to identify clients who need screening. And we're going to pilot a written PHQ-2 and PHQ-9 in 5 different languages. And then for our D ramp, referral to treatment, clients with depression will have follow-up, including warm handoffs, correctly documented in the chart. That's our outcome. Our process is to use a chart audit checklist to utilize and assess the use of standardized care plans based off of the CCNC toolkit and to guide ICD-10 assignments. And our balancing measure is patient visit cycle time. We're trying to not unduly lengthen the amount of time patients need to take for their visits. Again, kind of a full slide, but on the left is my PDSA Cycle 1 tests of change. Again, going by ramp. Ramp A, we're going to in-service providers and staff and begin using our Huddle evaluation tool. Ramp B, we're going to begin using the depression option grid in English, Spanish, and Arabic for our shared decision-making tool. And we're going to survey patients about their understanding of their care plan on our patient satisfaction survey. C-RAMP, we're going to, again, as I mentioned, use a chart audit for pre-visit planning and pilot our written depression screening in 5 languages. And Ramp D, we're going to use the CCNC Toolkit resources primarily with providers and use our chart audit checklist. Here in the bottom, we've got our stakeholders list, including our patients. And I do want to point out our potential barriers. We have many new staff, including in behavioral health, and yet we have some resistance to change expected from some of our experienced team members. There's a perception in our clinic that visits already feel rushed and full, so trying to fit that in could be a challenge. And then we have some challenges with documentation in the EHR. And as noted, we have language and cultural barriers in providing care. So here are my references. Thank you very much.
And I got 4 minutes and 59 seconds.
Holy moly. Okay.
Great job. Great
Awesome.
job.
Thank you.
Okay, we're just going to move on. We'll keep all your questions, your comments for Ann later. Again, make sure you're taking notes. And bye, honey. Oh. And we'll go from there. Who would like to go next?
I'll go.
Okay, Casey, let's see what you got. I'm going to put myself on mute. Let me know if you need me.
Okay. Desktop. Okay. I'm starting. So my project would be implementing the PHQ-9 in the GAD-7 questionnaire at a hospital-based facility. I work at it on-site at a hospital base where we see we see employers for same-day sickness, acute illness such as sore throat, ear pain, swimming infections, very acute episodic care is what we treat for the employees. And we also do biometric screenings. So the aim that I would like to do for this project would be to implement the depression and anxiety screening 80% by using the PHQ-9 and GAD-7 questionnaire on patients and conduct referrals for positive screens by 80%, up to 80% by September the 8th. Depression and anxiety is a medical condition that is most likely to affect every person at some time in their life. More than 1 out of 20 Americans 12 years of age and older reports depression. There's an economic burden of depression, including the workplace costs, direct costs, and suicidal-related costs, which estimated to be about $210.5 billion in 2010. Anxiety disorders are the most common mental illness, affecting 40 million adults in the United States, age 18 and older, or 18% of the population. The reason to implement this project, implementing the screening on each patient during the visit, will help fill in the gap in the literature. Healthcare providers should be more engaging to the topic of mental health and encourage patients to open up to have the dialogue. Shared decision-making tools are a great start to aid in increasing knowledge. The patients and families that may lack any information regarding mental illness. Screeners are a valuable tool that can aid in early detection, which can lead to a reduction in the cost of ER visits and treatments. Some of the benefits by implementing the screening in on-site will be, again, early detection, reducing ER visits, reducing medical costs, improving patient health outcomes, and improved quality improvement. So with some of my measures for team engagement, the outcome would be to increase teamwork on screenings and initiating the process for referrals on positive screenings. Process measure would be to increase staff teammates teamwork on depression and anxiety screening. So educating on the process, when and how to do a referral if there is someone who's screened positive. You can do pre and post tests for staff on how to conduct the questionnaire and the referral process. For the patient engagement, would like to increase patient awareness of signs and symptoms of depression and anxiety for those who screen positive by 80%. The process would be to conduct shared making decision tools with the patient using the Depression and Anxiety Toolkit and measures the patient knowledge of signs and symptoms of depression and anxiety with the POSE test. Process change 1 is mainly the screening. So we want to increase screenings by 80%. And the process measure would be to screen at least 80% of the patient using the PHQ-9 and the GAD questionnaire. And then the process 2 is mainly the referral for those who screen positive. And the process would be to audit documentation of the referrals, follow-ups for positive screenings to behavioral health providers within the system, using a log template. Balancing measures would be staff satisfaction, patient satisfaction, percent of complete follow-up calls, and then the availability of the referrals. Initial changes would be to test the cycles with staff members as a trial run, then conduct multiple cycles for a test of change and use a small population size for the first cycle. Some of the barriers would be patients not being truthful or willing to engage in the questionnaires, staff not complying to the change in workflow while implementing the questionnaires. We're given a short time frame, mainly 15 to 20 minutes per visit. And so if someone's screened positive, that's going to take longer. So that can be a barrier. And my stakeholder team is very small. So it's basically the patients, my supervising doctor, and my mentor, Larry Carpin, and then the MA that I work with that's on my team. And those are my references. I'm sure I was under 10.
You did it, 434. Good job. You guys are making it hard for everybody else. 434. Great. Good job, Casey.
Thank you.
All right, who wants to go next? Hello?
I'll go next.
Okay.
Okay,
And
give
so
me just
Kate-
a minute.
Yep.
I have a really bad habit of going overtime on these things, so I'm going to talk really fast, and then I'm scared I'm going to go really under time. So we're just going to see how this goes.
Practice makes perfect.
Um, Okay, how's that? Can you see everything?
I can. I'm going to mute myself. You tell me when you're ready to go.
Okay, I'm ready. So my project is providing effective patient-centered support to increase exclusive breastfeeding rates at Mercy Hospital in Des Moines. The AIM statement is that our goal is to increase the rate of exclusively breastfeeding moms and babies upon postpartum hospital discharge to 45% before September 15th. The problem is twofold. We have an overuse of formula for supplementation at our hospital. The Joint Commission says that a reasonable rate of exclusive breastfeeding after discharge is 70%, and Mercy Hospital is currently at 30%. There's definite reasons for change. Infant health, excessive formula feeding leads to an increase in many infant diseases, including SIDS, GI diseases, allergy, adult obesity, and many other lifelong problems. Maternal health can also be increased. Increased formula use leads to increased maternal rates of cancer, including ovarian cancer. It also leads to increased rates of diseases such as osteoporosis. There's also a financial health aspect of it. One study in Louisiana showed that increasing exclusive breastfeeding rates to 80% can save over $8 million a fiscal year on the health costs related to mothers and infants not exclusively breastfeeding. Benefits of change include increased health of our maternal and infant population, standardizing care between our from the birth process all the way through the postpartum process at our hospital. We believe that this change will improve client experience of care and will also improve Mercy Hospital Des Moines' community presence as a hospital who leads in working to provide the best health and wellness possible. For measurements of change, our first outcome is that 90% of nurses will report confidence in teaching and assisting clients in newborn feeding patterns. To chart that process, we will use surveys and mark how many nurses are able to state normal newborn nursing patterns, frequency and length of normal newborn feedings, etc. For patient satisfaction, we are looking at patients to feel more educated and supported in breastfeeding as measured by surveys. And in order to do that, we will have our lactation staff visiting breastfeeding moms, all breastfeeding moms within 24 hours of birth. We will also increase the number of couplets doing on-demand feeding. And to follow that process, we will use chart audits of the infant feeding. And we also propose to change staffing ratios so that at least 80% of the time, our night staffing ratio is 3 clients or 3 couplets to 1 nurse. And we will track this measure using staffing chart audits. For balancing measures, we're looking at nurse satisfaction with these changes. We're looking at mom's perception of staff pressure to breastfeed. Is she feeling overly pressured, or is she accepting of it? We're also looking at infant hypoglycemia and weight loss to see if those increase or decrease, and nurses' perception of available time. Our initial changes are a staff in service or education, lactation patient engagement, beginning to have our lactation staff be all breastfeeding moms within 24 hours of birth. Nurse teaching to moms, new staffing matrices, and infant transitioning. Our key stakeholders include unit directors, our pediatric hospitalists, and our nursing staff. The barriers are that this is the largest hospital in Iowa, and nurse resistance to change.
Are you done, Caitlin?
Yes, sorry, I'm trying to figure out how to not screen share anymore.
That's okay. There's a little same button that's going to say stop screen sharing. Okay. Okay, good job. So who would like to be next? I have Don, Nellie. Can't see if anybody else is over there. Just Don or Nellie?
I'll go.
Is that Nellie?
Yes, I'm sorry, yes.
Okay, okay. And Nisa, can you just make sure nobody is texting us to say they wanted to get in? I'm not getting any, I don't think, but I'm trying to do timing too. Okay, Nellie. Can everybody else see Nellie's? Because I have a blank screen. Nisa, are you there?
Sorry, I was muted and I didn't realize I was
No, that's
muted.
okay.
I was talking away.
I'm gonna, you gotta do this one because Nellie's blank for me.
Okay, I see Nellie, but I don't see your screen shared yet. Okay, it looks like you're working on it.
It says you are screen sharing, but it's a picture of you.
And then
I see.
pull up your whatever it is your screen. Pull up your AIMS slides or Prezi, and then put that on your screen. Okay. So that's what you see, and then that's what we'll see.
Perfect.
Okay, great.
Yeah, I really wish I could. Whenever you're ready.
Okay, I'm going to start. So my project is implementing recruitment and retention strategies to increase the effectiveness of the Nurse-Family Partnership Program by increasing family engagement. So the Nurse-Family Partnership is a home visitation program that pairs low-income first-time mothers with a registered nurse that has the goals of improving pregnancy outcomes, improving child development and health outcomes, and improving self-efficacy. The AIM statement is to increase efficiency of the nurse home visitors in the implementation of the Nurse Family Partnership Program by increasing family engagement, which includes recruitment and retention by 30% by September 10th of 2017. So according to the Feiner and Zollner of the Guttmacher Institute, in 2008, 51% of all pregnancies in the United States were not planned. Sonfield and Cost from the same organization estimate that the United States spent a total of $12.5 billion on births resulting from unintended pregnancies in that same year. It is estimated that NFP costs roughly $1.6 billion. However, it is estimated that NFP will be able to decrease spending on Medicaid, TANF, and food stamps. A 2005 RAND report identified a $5.70 return on investment for every dollar spent on every client enrolled when a nurse home visitor carries a caseload of 25 clients. The World Health Organization recommends that all women receive a home visit by a provider within 1 week of delivery when they are of low income, low resources. In April of 2017, an audit of 20 charts was completed at the NFP. This showed that 45% of postpartum women received a home visit by a registered nurse home visitor during the first week of delivery. World Health Organization also recommends that postnatal women be advised of the postpartum danger signs. And of 20 charts audited, 85% of nurse home visitors reviewed danger signs with their clients. In addition, after completing a patient tracking from receipt of referral by the agency to scheduling of that first home visit, there shows a multi-step process that allows for the client to lose interest in home visitation services during the lag time. Lag time is an average of seven days, ranging from 1 to 14 days. Expected outcomes. So increasing recruitment and retention by affecting family engagement will ultimately increase overall program participation, which works to keep the program sustainable. In this project, the Passaic Nurse Family Partnership team will be better equipped to deliver the NFP program with fidelity to the model. This will improve job satisfaction and employee morale as the nurse home visitors learn how to improve the patient experience of care. The measurements of change. So RAMP A, the team RAMP, the test of change is the recruitment and retention intervention. And this process measure increases nurse home visitor team awareness of the strategies used to increase client engagement by September 10th of 2017. The outcome, increased nurse home visitor buy-in and capacity to use the new strategies. The patient RAMP B is the patient-driven visits. Process measure increased the number of nurses offering client choice of topics for subsequent visits by 50% by September 10th of 2017. The outcome measure, the nursing documentation will show a 50% increase in the client chosen topics that are adhered to. Process C, the process 1 RAMP. The test of change is the process of referral to enrollment. The process measure is to increase the number of clients going through a new one-step process by 20% by September 10th of 2017. And the outcome measure, decrease in the mean cycle time between receipt of referral and enrollment. RAMP D is use of a strength and risk assessment. This process measure is the increased nurse home visitor use of a STAR framework strength and risk assessment by 100% by September 10th of 2017. The outcome measure is an increase in the use of strength and risk assessment during one-to-one supervision and case conferencing by 50% by September 30th of 2017. In terms of balancing measures, I have nurse home visitor job satisfaction and central intake productivity, since they are the step that's being eliminated from the process of client referral to enrollment pathway. In terms of stakeholders, we have myself, the Director of Education, Amy Cole, the NFP Program Administrator and Chief Operating Officer, Liliana Panett, all of the nurse home visitors on the team, the Administrative Assistant, and Dr. Diane Jollis, which is the FNU Advisor. Barriers to this project, I foresee time being a barrier. For some RAMPs, there isn't enough time to see the type of changes that make a a large difference in the operation of the team. For some RAMPs, there may be too much time. The other barrier I see is getting staff to buy into some of the RAMPs. Half of the NFP team is very seasoned and accustomed to implementing the program a certain way. Any changes are seen as an intrusion and also as an affront to how they've been working all along. Any type of change needs to be introduced very delicately, which is the intention. And the initial change, and the one that's going to affect all of the RAMPs, is going to be more organized and consistent team meeting educational modules. And I think that one is what's going to drive the entire project. And these are my references.
Okay, great job. Just over 5 minutes. I think I might give it to you.
Okay.
5 minutes, 12 seconds. Unless,
Oh, man.
unless Lisa's got something crazy different, I think that was pretty darn close. All right, Donald, I think you're the only one left.
Okay, can everyone hear me okay?
Ken,
All right, let's do the screen share.
I'm going to mute myself. You tell me when you're ready, Donald.
All right, let me screen share. Share. Can everyone see my project? Chance? Okay. All right, I'm ready. My name is Donald Burdine. This is the endgame presentation. The title of my project is Diabetes Outpatient Care Utilizing National Performance Measures Efficiently to Educate and Improve Patient Outcomes at Lake Bennett Medical Associates. My aim statement is to increase comprehensive diabetes care for all qualified patients through the use of national quality measures to 65% before September 15, 2017. This aim statement identifies the 3 fundamental questions of how good, 65% for whom, qualified diabetes patients, and by when, which is September the 15th, 2017. The problem identified, approximately 29 million people are diagnosed with diabetes in the United States, and an additional 86 million people have prediabetes. It's estimated annual healthcare costs associated with diabetes is $245 billion and projected to increase to $500 billion by 2020. And a third reason is research suggests correlation exists between quality performance measures, guideline adherence, and clinical outcomes, which can decrease unnecessary hospitalization and can contribute to decreased and diabetes-related healthcare costs. The rationale for this QI project: 20 charts of patients diagnosed with diabetes were reviewed from April 2017 to June 2017 at Lakeside Medical Associates. The results of the review showed that 15%, 3 of 20 patients received a controlled hemoglobin A1C, 50% had controlled blood pressure less than 140 over 90, and 40% received a retinopathy screening, as well as 58% of the patients received nephropathy screenings. The identified measures directly impact the financial stability of the practice and contributes to overall increased costs of healthcare for diabetes. Therefore, educating patients on comprehensive diabetes measures and efficiently utilizing these quality measures can help optimize patient experience, reduce unnecessary healthcare costs, and significantly impact patient outcomes. The expected outcomes for this quality improvement project include improve patients' clinical outcomes through education and reinforcement, standardized care related to comprehensive diabetes care encounters, improve patient experience of care and satisfaction. Number 4 is to increase staff awareness for importance of monitoring patient quality measures. Number 5 is to improve staff identification tracking capabilities. And number 6 is to improve staff function through interaction around a common concern. The measurements of change identified the outcome measures and process measures. As you can see, the process measures is flipped on the screen. For RAMP A, the team increased staff participation and engagement through bi-monthly staff training meetings related to quality measures for comprehensive diabetes care by 70%. The outcome measure, which is on the left-hand side of your screen, the team will demonstrate understanding of the importance of screening with an increased prepping of patient encounter folders with needed tools and forms for 70%. Going back to the process RAMP B, patient engagement, the provider will complete and provide health tracker education tool to the patient, and the patient will complete the accompanying special form for 70% of encounters. And then the outcome measure, increase the number of diabetic patients who indicate an understanding in the monitoring of their diabetes care through the use of the special form for RAMP B. The process 1 change for RAMP C is to complete the audit worksheet for diabetic patient encounters for 80% of the encounters by September 15, 2017. And process 1 outcome measure for ramp C is increased identification of properly documented diabetic encounters using quality performance measures as a guide to 60%. Process 2 is utilize the EHR tracking system to identify and track diabetic patients who require referral service and initiate follow-up for 85%. And the outcome measure for process 2, ramp D, is to increase diabetic patient follow-up encounters for referrals to 75% of all qualified patients by September 15, 2017. The balancing measure identified affects ramp A and ramp C, teamwork and process change 1. And the balancing measures team will increase process productivity by 10% within 1 week from the identification of workflow decline and upon each revision through September 15, 2017. Initial changes, barriers, and stakeholders. Change ideas include, number 1, interviews with select sample patients volunteering to provide feedback about the process. Number 2, interviews with team members willing to provide feedback about the process. Number 3, surveys completed by team providing feedback and opportunities for change and improvement. And number 4, utilize cause and effect diagrams to help identify and troubleshoot problems. Barriers associated with this QI project include, number 1, lack of interest from patients. Number 2, team burnout. And number 3, lack of interest or participation from the team. And the stakeholders for this QI project include the following: Dr. Sadek, the mentor, the site sponsor, the medical assistants, discharge coordinator, compliance coordinator, case manager, and myself. The only one lacking on here is the FNU faculty advisor. Here are the references, and that's it.
Great job, everybody.
Great job, everybody.
Donald, I got
Donald,
you
I
at
got you at
6:03.
6:03.
Oh, well.
But it was still very
But it
good.
was still very good.
All right, so now what I'd like to do is I'd like to, first of all, I want to ask you if you have any questions that are pressing that you want to talk about. And then what I'd like to do is we'll look at different parts. And what I would encourage you to do, as I said, this is our third touch point, our third possibility of helping you before you submit that final charter, and really have to have all your ducks in a row, because hopefully you'll take some time off after the break, during the break. And then really when you come back, we are starting right at week 1. You'll get your run charts up and ready to go. You'll have to know exactly what you're measuring. And at that point, it's like a race. So we really want to have this opportunity to show you, to discuss things that you're struggling with, if you're not sure of your measures. My feeling really is that you all should be able to do the research, pull the charts up, get that kind of stuff. What I really am concerned with and always want to help you with is your measures, because that's kind of the nuts and bolts of the actual project. So first of all, I'd like to open it up. Nisa, do you have anything that you wanted to say first?
Mostly that everyone did a great job. I have a little bit of a metric that I'm using here to kind of track like what the measures look like and how well things seem to line up. And while the presentations were only 5 minutes, so I didn't have a lot of time to think deeply about each one, I was impressed. I think they really look good.
Yeah, you guys are in a great spot. All right, so who would like to, do you have any questions?
I do.
Okay, go ahead, Case.
I think I might be a little confused with the test of change. I know there's going to be every 2 weeks we're doing something different. Will it be like the ramp A, B, C, and D? Is that like week 1 is going to be the teamwork? The following 2 weeks is that how it's going to be?
Yep. So what happens is this is a rapid cycle change, which means our cycles are every 2 weeks. However, I would encourage you all, this is a great question, thank you. I would encourage you all to be collecting data, if possible, every 3 to 4 days. Because if you aren't collecting data every 3 to 4 days, if you're collecting, the cycle is 2 weeks, but if you, for example, waited 2 weeks to see if your form worked or your survey worked, you have lost 2 weeks of data if it's not. What if they're not collecting it? What if they hate the form? What if the whatever. So it's great if you can be collecting data every 3 to 4 days, twice a week. And that way, if you are using a form or what your process or whatever, and you find after 3 or 4 days, okay, 3 days, it's not quite working, I'm going to give it one more day. You look at it one more day, even though you were going to wait 2 more days, and you see that, gosh, this is not working. You go ahead and make that change right then. You know, your staff hates the form that you're using. It's you loved it, you thought it was very inclusive, but it's 8 pages. So you get together with your team, because if you get together with their team and get their thoughts, and you know, there's always a balance there, right? They're not running the project, but there's always a balance. And if you include them, i.e. engage them, they have buy-in now. They say to you, you know, I love the idea, but man, this form I can't get this done. I'm 20 minutes late on my patients. So together you sit down and you kind of say, okay, we could get rid of that piece. We could get rid of this piece. So the forms, tools, things that you're using do not have to be used in their entirety or the exactness of what you're using. Does that make sense, Casey?
Yes.
Casey,
So, yes.
I just want to clarify really quickly, just in case there's anybody that wasn't 100% clear on this part, that on day 1 of next term, you're actually going to implement all 4 ramps on that day. Your A, B, C, and D ramps, you're going to implement all of them that day. And then those tests of change are going to be the small things you're doing. You know, what are you doing on the first day? And then 2 weeks in, you're going to have tweaked those things. You're going to be looking at your data, that whole PDSA thing, right? You're going to have acted, and then you're going to be looking at all the data, figuring out what you're going to do next, and creating a new, new changes. So maybe you're going to tweak the form so that it's not 8 pages anymore. Now it's 2 pages, and then you're going to do that for the second cycle. And each one, A, B, C, and D, are going to need some changes each cycle moving forward until you get them, hopefully, you know, absolutely perfect at week 4, right? Or cycle 4.
Okay, that leads to a question I have. So kind of the opposite. I found myself thinking about this. What if on one of your ramps, like in the first or the second cycle, you get like amazing results and you're like, oh, this is great. Like there's actually nothing I need to tweak for the next one. Do you just like stay the course and see if it's consistent? Do you broaden how many patients you try to do, but like leave your intervention kind of the same if it's looking really, really successful?
Yeah, that's a great question, because it happens miraculously now and then. And so when it does happen, what you'll do is exactly what you said. You either look to, can I dig deeper? Is there something, okay, like this is great. This is the initial thing we wanted to do. Can I dig a little deeper and do something more or better? Or can I spread this to a larger quantity of patients? And most of the time, I think if it's working really well, you'd want to spread it.
Yeah, okay, that makes sense. Thank
The
you.
other thing to think about is that quality improvement is never done. So if you have an amazing team and everything works really well right off the bat, and we've had that happen. We had someone who was doing screening with asthma using some screening test. I don't remember what it's called. And it went and literally all her ramps went up to 90 to 100% within at least the first cycle to cycle 3rd week, which is the beginning of the 2nd cycle. So we said to her, okay, and she was done. That was her whole team. She didn't have another office. So she added flu vaccine. It was fall. And so flu vaccine, we said, what else is important to asthma? Well, asthmatics, it's not good if they get the flu, right? So we added the screening for flu vaccine. So, you know, depression, are we screening depression at the end of postpartum? Well, do we need to be talking about it at the very first visit? You know, so you can always, that's what dig deeper. That's where Denise is looking. You spread or you make it bigger, because there's always quality improvement to be done. So we can only hope, Anne, that you're going to be blessed with moving this along very quickly.
Well, I have been blessed so far with a really supportive team and everyone's really on board. And I mean, I don't know what will happen, but I was just wondering, because we spend a lot of time, I think, thinking about what if this doesn't work? How do we tweak? And I thought, well, what if the opposite happens? So,
Exactly.
yeah.
And you know, the other piece that I'm really glad you brought up is, oh shoot, I just lost it. You said, what if it doesn't work? It'll come to me.
Oh, we spent a lot of time talking about what if it doesn't work and we need to make, I don't know.
Yeah, it'll come to me. It'll come to me. All right. What other questions? Don, you look like you wanted to say something.
No, I was just going to say, like, to her point, what helped me with what you were just about, I don't know if this is your train of thought, but during the buzz session, Kara was in my session And she said, you know, to the point, if you're OCD like me, is what Kara said. She said, you can't go into it expecting that it's going to change, because it may change 100 times the opposite direction, or exactly not the way you want it to change. So, you know, instead of planning it out to the very end, you just have to let it take its course. I don't know if that helps anyone, but that helped me out a lot, because I was so I was in anxiety, having some anxiety, thinking, okay, well, how am I going to get this to this point? When she made that comment, it was like a slap in the face. Okay, take a step back and allow it to take control, and you follow it.
Yeah, that's perfect.
As long as you have the initial, like, you know what you're doing, you know what your goal is, where you're trying to get. That's why that aim statement is so important. That's exactly what you want to do. You want to have faith in the system of gathering your data, and then, so this is what I will go to the second step, sort of your next step once you gather that first set of data. There's a section called prediction, and there's a section called learning. Make sure your learning is not a rehash of your results, but actually, what did I learn? What did the data tell me? Oh, and that's what I was going to say. The other thing was, remember to think about your ramps. Everything that you do, every single thing that you do, you should be thinking, okay, barriers. Have I thought of my barriers for each of my ramps? Have I thought of my, you know, stakeholders? What are they going to do? That's not really one of them. My measures each has a ramp. So everything that you think about the whole way through this whole next term, always put that ramps in your forehead, because it's going to organize not only your thinking, but you're going to be so grateful to us when you get to the end of this process and you can actually think about how to write this up, because it's going to be very clear to you. Oh yes, I always addressed my ramps. I always had a test of change. I always had one of those things. I think that was.
Uh-oh.
Looks like we're frozen.
And I'm sorry, I got kicked out for a minute earlier, but I had to come back in. It worked.
That's okay. Nellie too. I'm not sure.
Yeah.
Not sure what's going on, but
Yeah. Okay. Oh.
all right. We'll keep going. It's just like if you were in a regular meeting in a real boardroom and, you know, people had to get up and blow their nose or something and go to the bathroom. So it's not a big deal. So let's, who has questions about the actual, like about their ramps? Like as you listen to other people talk about their measures and all of that, did something come up that you thought, you know, oh, that kind of sparks a question for me?
You know what? I have a question, because going back to what someone alluded earlier, say you have, you have the ramps and you have ramp 1 through 4. What happens when you go back and revisit it and one, I don't know, say ramp A wasn't very successful, but all the others were successful? Can you carry those forward and then revise ramp A for the second component? That's how I'm interpreting it. Is that correct?
Right. And so what we're going to do is always talk about the actual individual ramps as A, B, C, and D, and those are going to carry through for each one of our cycles. And the cycles will always number 1, 2, 3, and 4. So say like your patient engagement was just totally awesome, working great. And then one of your ramps, maybe it's your staff engagement, just, you couldn't really get people engaged, couldn't get them to come to the meetings. Nobody's, whatever survey you gave them, they all said was terrible. They hate it. They hate everything you've said. Yeah, that probably wouldn't work, actually, now that I think about it. If they hated it all, the other things wouldn't be going great, but we'll just pretend. So, so if it were, then as you move into the next ramp, you're going to be thinking through that PDSA cycle. You're doing the whole cycle for each ramp, really. So for your A ramp, your staff engagement, you planned, you did, now you're going to study that data, and then you're going to act on it. So you're making your thoughts about what are your changes moving forward for staff engagement. And then the same thing for patient engagement. What does your data say about what happened? And then what do you want to do moving forward? So you're going to have tests of change each cycle and little tweaks each cycle for each one of your ramps. It's like you're running 4 projects at once, except that none of the projects would work if you didn't run them all together.
That's how I'm taking it. So that's good.
And if you also think of it, sometimes if you think about running 4 separate ramps, it's a little overwhelming, like, oh my gosh, but you would never start a project without informing the staff. And then you would never, if the project is about the patient, of course you're going to have some sort of shared decision making or something with the patient. And then you're trying to get somewhere. You're trying to screen them more and refer them more. So it is for parts of it. It's really processes, but it's one project.
Mhm.
I do want to, Diana said out last week, one of her little announcements that it said, I know it's so easy when it's sort of like, what do you call it, alerts, when you get too many alerts on your computer. But you should open those because they're really wonderful. And one of them really struck me, and it was called Educate, Engage, Empower. And if I could tell you anything, it would be that you have to educate everybody. They all have to know what you're doing and what your plan is. Then you have to engage them. Because education, as we know, if it's one of your tests of change, will my education change their patient behavior or the team's behavior? I might have to shoot you. It doesn't. I mean, it might a little bit, but it doesn't. We all know we shouldn't be smoking, and yet look at how many people smoke. We know Pap smears saves lives, and yet they're not getting done. So it's got to be more than education. So it's educate them, engage them, and then empower them. Empower everyone on your team to make some changes, to be the other point that I want to make is how you sell it. So it's not that, oh my God, we're doing this project and this is what we're going to do. Nobody's going to want to do it. Did you know the problem nationally is blah, 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 blah. You all did a really great job on it. And our data shows that we're doing 20%. I mean, that should speak for itself, right? So then you fire up your team. So if you don't have any other questions with that same thing, I would like to get to your pieces parts. Does anybody have anything else that they wanted to ask before we get to your specifics? Because we're already almost an hour in. No. Okay. So Nisa, do you have anyone's that you felt like their aim was just super, or does anybody have an aim that they are just super proud of that they want to share? I thought you did a really great job with your aims.
I actually thought all of them were pretty good. I didn't have any that, I didn't have any, although I will tell you that in when I'm grading these things, I stop and think about them a lot longer than I was able to stop and think about.
So yeah, we're trying to do touch points here. This is not, it is very hard to do these, as I'm sure it is for you to do when they're so quick. How about Casey? Can you put your aim up? Can you share that with us? I just picked you out of a hat, Casey, because I also thought they were all good.
Oh, shoot.
So you all at this might want to have your project up, your PowerPoints up, because we're just going to go through and pull things from people.
Can you see my screen?
I see you.
Okay, let me.
Great. Okay. I have a horrible echo. Do you all?
No.
I hear yours. Oh, yes, it's on me too.
So everybody and then please unmute whenever you want to say something. So I'm going to move this up here. I'm still echoing. Is that better? What are the good things and work areas that you need to work on this? Anything? Does she have by when? Let's start with the easy. Does she have for whom?
No.
Oh. Thank you. That was it, Nisa. Okay, so who is this for? Casey, who is this going to be for? Nisa, you're muted.
Casey, I muted you because of that echo. So, so you can unmute to answer, and then if you'll just mute yourself again so that it keeps that echo down.
No, go back to your aim. There you go. Casey, who are these patients? You have to unmute, Casey. Nope.
Yeah, I have to go, for me to unmute, I had to go back out. Okay.
Oh, I'm sorry.
You don't actually, but that's okay.
Okay.
So
It's
who-
for on-site patients.
on-site patients. And on-site is you're in the clinic, in the hospital.
Yeah, the clinic, yes.
But it's a hospital, it's for the staff?
Employees.
Okay. Lisa, maybe you can talk her through this.
Sure. So I'm sorry. I'm going to go ahead and mute you again really quickly. For some reason, it's hard for me to. Okay. So when I look at that, when I see the for whom, and we see implement depression screening and anxiety screening 80% by using the PHQ-9 GAD-7 questionnaire on patients. So patients is a for whom, but we want to be more specific about which patients. So you could say patients at blah, blah, or patients who qualify, or, you know. So I'm going to unmute you, Casey, and then tell me a little bit more about who those patients are, as soon as I remember how to unmute you. Okay, so I'm sorry. It appears that I actually can't. Like, I can mute you, but I can't unmute you. It won't. I'm clicking it and it will not let me. So Casey, if you go to the top of your screen, I think you'll see a little icon that will pop up, even if you're screen sharing, that says mute microphone.
And Casey, I think also if you don't even have to go out, if you just click on your, I think you should be able to get to it if you just shrink it down. That's fine. You can stay out of it. We just want to hear your.
Okay, that's the only way I know how to get back to it. So the on-site patient, well, the patients are employees at the hospital. So the facility is called on-site. So I guess would I say on-site patients?
Casey, I wish I could say it again. Is because you're not saying diabetes screening or something. I think it might be helpful to know that these are hospital employee clinic patients. I'm not sure. Lisa, what do you think?
Yeah, if on-site is the name of the clinic, what is the full name of the clinic?
On-site annex.
Okay, so then you could say like the name of the hospital on-site clinic patients.
Okay.
It just, I would love to have it be, because you have sort of a different role. You don't, these are your patients, but they're staff. It's interesting. But you have everybody there. That's what I mean. We may decide to skip that. You have for whom, by when, how much, and the name of the questionnaire, the name of the tool. So that's great.
Okay.
It was good, Casey. I was not picking on you.
Oh, no, any help I'll take.
All right, let's look at a couple problems. Let's see. Anne, can we look at your problem?
Okay, hang on.
Yep,
I didn't have my microphone turned on.
no worries.
Okay, so we're getting to the problem. There we are.
So does Anne have something here that jumps out and says, wow, we need to do this now? Because that's the purpose of the problem. Like, get out of your seat. Man, this we need to do this right now. Does she have that grab right here?
I can't see it.
Click on Anne's on the bottom. Click on Anne's name. On the bottom of your screen where you see everybody.
So I will tell you, Anne, in my notes, I actually didn't even remember what you had said on problem because all I wrote next to it was wow.
Oh, that's good. Yay.
Yeah, and I mean, super job here. She's got an economic burden of get out of your seat, $210 billion. And she didn't just say 200 billion or many billion. She said $210 billion annually. You know, that is like a serious chunk of change.
Mm-hmm.
Leading cause of disability could have gone a little farther with there, but it's great. It goes undiagnosed. And again, she brought in the social disparities there. She has referenced them beautifully. And it's also higher in people with comorbid conditions. So just, I mean, it made me get up out of my seat. And that's what the problem is. This is how you're going to present this to your staff. So here's what our goal is. This is why the problem in the country is blah, 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 blah. Beautifully well done. Again, referenced money, illness, health to the patient. All of those pieces are just, and short and sweet, you know, bam, it's like a blow to the stomach. Great job. And that was a good blow.
Thank you.
All right, let's see. Nisa, who should we pull up for the rash? Does anybody have questions about problems? I don't want to go past here. I think you all did a pretty good job. So your problem is the big picture of why this is not just your local little place. Okay, so big data.
So
Anybody
Nellie,
have questions on that?
Oh, go ahead.
Nisa, what were you going to say?
So I was going to ask Nellie to pull up her rationale or her reason.
And that it does bring up a great point. I'm just going to bring it up there while Nisa's bringing this up. In your charter, the reason is different than in your PDSA, the rationale, or the paper. Sorry. The reason and the rationale in the PDSAs and the charters are the same, but when you get to your paper, it's a little bit different. The rationale they're talking about is what is the theory or model that you used? Was it the SPURT or the rapid cycle? So that's a little bit, I just throw that out there for you so you don't get confused. Okay, Nellie. Nisa, you want to go here?
Sure. Will you go back to rationale? There you go. There, now we can see it. So what we were looking for here is to be able to see so some local data. What is going on right now? What is the chart audit? So I liked that you put that in there, your local stats, what's happening. And then, you know, why do we want to do this? So I really liked this part of it. You said 45% of postpartum women received a home visit by a registered nurse during the first week after delivery. So the only thing that I can see there is, I like that you said 45% received. I would love for you to kind of flip that. Like, what is it that you're looking for? So did 55% of women didn't receive a home visit? Like, is that the thing that we want to correct? But I like that you have this local information.
Okay, that's exactly right.
That's a great point, Nisa, because it does bring it a little bit more, we need to do this.
Yes. And I liked also that you said that it was from referral to schedule a first home visit was the average of 7 days, because that is kind of a long time. And if you're like, it seems like the real punch, the real benefit there of that home visit is to get it done really quickly so that you're really getting in there when problems are at their worst or when they're really developing.
Right, and I think
Go ahead.
With us in particular, it's a little tricky to have, you know, to get some of these women into home visitation services. And, you know, if you get them while they're freshly referred, meaning the social worker, the midwife, the, you know, WIC worker, whoever it is, it told her about the program, and you can get her, you know, scheduled for the visit, the sooner, the better it is, because the longer they wait, they forget what they've been told, and then they kind of, you know, lollygag and decide not to enroll.
The only thing I was going to say there is you might want to add underneath there, because if you're not in OB, you don't know that. So you might think, dang, getting him into referral within 7 days is pretty good. You might want to put underneath there some statistic where the biggest % of our problems come, or
Okay.
what the national goal, the goal is to be in there within, 1 to 3 days, and we're getting something that shows that that's 7 days, because other people aren't going to know that.
Okay.
So this part is, again, so you did your problem was the big picture, problem, money, health, and now what you're doing is you're actually, there should be a flow. So what you talk about in your problem should come down here to your effort. If you're talking about money, great if you can talk about money. If you're talking about health follow-up, great. Eventually, in your reason, you are going to want to have, and everybody listen because I'm going to say this many times, every measure you have, if you can, now that we're refining these measures and getting them really down, you want to have baseline on every measure. So if you are measuring postpartum visits, if you're measuring specific parts of the process, if you're measuring what day it is, whatever you are planning on measuring, if you can get baseline now some of it, if you're going to use a new form, you can't. However, just like Nellie's done here, she may be using a special form. She may be going to have a new form that she's figured out that's going to track everybody. So obviously that's not being used. However, the point of the form is to track the postpartum visits, when they got there, what time they got there. So you now have to go through those 15 or 20 charts and pull all that data out and say, out of 20 charts, 3 out of 20 had this, 7 out of 20 had this. So look for that baseline data for all of your measures right now. I would like, very good, Nellie, and thank you for sharing. Caitlin, can you pull your problem up? Thank you, Nellie. Oh, poor Caitlin's got her audio issues. So problem's the big picture. See if we can get down to.
So did you want the problem pool?
I think I wanted the, Caitlin, I wanted your problem. And then
Here's
I
my
want
problem.
Yep. So overuse of formula for supplementation, Joint Commission rates. So the Joint Commission rates versus hospital, that is a great piece of data that could go down and especially, I can't remember if you actually had the rates, that can go down into your local data, your reason. So what you want to do here, oh, you've got your notes over there, how wonderful. Joint Commission, great. And then your rate would go down below. But what I want you to do here is, Caitlin, you need a kicker, right? What are some pieces of data I don't expect you to have this memorized. What are some of the things that are just so important for this? Off the top of your head, just from what you know.
Well, that's kind of over in my reason for change. The increased SIDS, GI infections, necrotizing and allergies, obesity, cancer, depression.
Beautiful. Yep. So you just had it flipped, and that's a very common thing.
A savings of $2 billion per year.
Your reason, that's all, that should be in your problem. That's perfect. Great stuff, but put that up in your problem. So the problem is the overall big picture. And now if we go down to your reason, the reason should really be local data. I pulled 20 charts and this is what we had. Does that make sense?
Yep.
Okay. Beautiful. But you have great data there for your reason. And it's very common for people to flip those and have them in the wrong place. All right, how about any other questions on reason? So you're looking at your gap analysis, your tracer, your fishbone, all that data that you've been working so hard in collecting, this is where it goes. That's what leads to your reason. It helps you to pick out what you're going to look for. Okay, any other reason questions? Okay, how about outcomes? Who hasn't shown me outcomes or anything yet? Anne's done some, Nellie's done. Donald, you're up.
Okay, let's see here. Share. Share. Can everyone see?
Donald, yep.
Again,
Okay.
they're flipped.
So do you mean they're flipped, meaning your outcomes really should be where your processes are?
Correct. Well, in my mind, that's how they should be.
Okay, okay. So you're not saying, are the outcomes really what you think are the outcomes? You just want them on the right side of the page?
Yes, correct.
Okay,
The
okay.
outcomes are the outcomes, the process of the process.
Okay, okay. So one of the things I want you to ask yourself, each person, so you have your aim, and everybody's aim was good. So you're off to a good start. Does my process lead to my outcome? And if my outcome is fulfilled, will it lead to my aim? So if we look at Donald's first process for his team, actually, Donald, pick your favorite outcome and process. Which ramp is your favorite?
Oh wow, that's hard. Let's see. Let's use either A or B. I mean, let's do B.
Okay. So the provider will complete and provide the health tracker education tool to the patient, and the patient will complete the accompanying special form. So these are two parts of a whole, right, Donald?
Right. Yes, ma'am.
Okay. So there's two tools, which I love, that the patients and the provider are going to use. That brings me to a point of, there are things called decision aids, and there are things called shared decision-making tools. A decision aid is, I just had a student who shared everything with me, and she has these lovely decision aids. Decision aid can be something that is just an informational piece of paper. It might be a wonderful piece of paper, but it's a piece of information. It does not necessarily make you share. A shared decision-making tool, and I don't know what these are, Donald, so I'm not saying yours are or aren't. A shared decision-making tool means there's a part that the patient has to do. They have to partake, i.e., big word, engage. And there's a part then that the provider has to respond to and engage in also. That buys you engagement.
Right.
Okay, you can take a decision aid and make it into a shared decision-making tool by adding a couple questions at the bottom.
Mm-hmm.
So make sure your tools, because if you don't, we all know what happens, right? We have a busy day. Did you hand out the shared decision-making tool that really, i.e., wasn't a decision aid? Well, yeah, I gave it to them. And so there's where the problem is. There could be no buy-in there. Okay, so he has these two things that both the provider and the patient needs to do. And does this lead to an increase in the number of diabetic patients who indicate an understanding in the monitoring of their diabetes through the use of the form? So we are saying to Donald, we don't see these forms. Donald, if they do these tools, does it lead to increased understanding? Is that one of the questions that they measure?
Yes, that's my hope. Because the fact is, I guess the health tracker education tool as well as the special form, I combine the two forms to do exactly like you just said, utilize it as a shared decision-making tool, but it's twofold. It comes from the provider to the patient. There's a aspect that the provider has to complete along with the patient, and then you're soliciting information from the patient to determine if the education was there and how well they understood it, with hope that through this process that they will understand or provide or achieve a greater understanding for the monitoring of their diabetes care through this comprehensive diabetes initiative.
Great. That is so you're asking, does the process lead to the outcome, and does the outcome feed into your aim? Now, I'm going to ask you all one question. Everybody's familiar with Bloom's taxonomy, right? So if we understand something, if I know about all the things that I should be doing for my diabetes, Does that make me do it?
No.
No. So what are some of the things I'm moving? Because I think my son is coming home from the airport, so I'm asking your forgiveness when I give him a kiss when he walks in. What do we need to? What are some of the things up on the higher levels of Bloom's taxonomy? Somebody pull that up real quick. You guys are not fast. Who's going to get it?
Is it creating, evaluating,
so
analyzing, applying?
Yes, yes, yes. So the more you move up that ramp, that's why Teach Back is so effective, right? It's so useful because they have to bring it into their head. That's why in Centering Pregnancy, when we facilitate discussions, and we don't just say to them, blah, 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 blah. Whole reason why there is some learning there, and it's deeper learning. And that's what you're going for, because deeper learning is engagement. And remember, education is the first thing. We got to do that. So that's my only concern, and I just throw that out there again. Educate, engage, empower. 3 E's. So the more that you can use up that higher level of Bloom's taxonomy, the more you're going to get from everybody, from your team and your patient. So Donald's got 2 great tools, and he's having both of them use them, and then a standardized discussion, but it makes you have to discuss. You also can cut and paste and chop and tweak your tools as you need to. You do not have to use a tool in its entirety. Because if you go to your team and you say, this 7-page tool is so great, and you guys have to do all of this before the patient even gets in the room, they are going to kill you. All right? Okay, great example, Donald. Thank you.
Okay.
Anybody else have questions about their measures? This is the hardest part and the kind of the nuts and bolts of it. So if you have questions, please ask us now. Anybody want to share theirs and go over anything, the outcomes or the processes? Ask yourself, does my process lead to my outcome? Does my outcome, if fulfilled, lead to my aim?
I have one more question that's maybe more of an observation. God, I'm getting an echo. Okay, that's better. So let's say, unlike what I asked before, what if one of the ramps, something totally is a dud, like a questionnaire or a tool totally does not work, and in a subsequent ramp we decide to change it? It's really important that our measurement not be tool specific, right? Because in terms of a run chart, you're going to be tracking the same outcome even if you're using something different to get to that outcome. Is that right?
Yes. Sorry, I had to hug my boy.
Oh, okay. Yeah.
Yes. Yes.
Mama boys too. Yeah.
Yes. 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 He just came home. I haven't seen him in a while. Absolutely correct. It is the ramp of the team. It is the ramp of the patient. And it's the ramp of your process. It's not specific to your tool, because you're right. You may decide this tool is not working.
Mm-hmm.
So
Okay.
it's just getting you to where I always say to the people, put your aim right here. Put your aim on your forehead every day. And am I getting there? Is this because it is a temptation to have a wonderful run chart or a wonderful, we worded something so nicely that we just love it, Write it down, put it somewhere else so you can keep it. You haven't thrown it out. But we have to be going towards this road, towards this goal. Did I answer that? Because I only caught half of it while I was hugging my boy.
Yeah, no, that makes sense. Thank you.
Okay. How about anybody else? Anybody with measure questions? Really, the measures, I'm telling you, it's the hardest part. So if you have questions, please ask us, or feel free to, contact your faculty person.
For the outcome measures, we need on the measure worksheet, we need to list, I guess for each outcome, we need to list the operational definition.
Every measure, outcome measures, 4 outcome measures, 4 process measures, you only need one balancing. Many people put, and I love you that you think you need you're following the ramps and you had a balancing measure for each ramp. You only have to have one balancing measure. Now you can have several, but it's more work for you, which is okay. If you feel it's something useful, measure it. But and the measuring will become easier, but you only need one balancing. But yes, you need 4 operational measures, 4 process measures, every single one of them operationalized. Because when you walk in the door on Monday, Casey, and this is the famous IHI saying, by Tuesday, what are you actually going to do? And so you don't want to be going in on Tuesday going, I wonder what I'm measuring. You want to know exactly. And you've all done chart audits. So you're going to make yourself a chart audit tool. And you're just going to say, I'm going to measure were my forms or my shared decision-making tools used? Do they have writing on them? Are we uploading them? How am I going to know that? I mean, how are they going to get to me? That's part of that process that you're thinking about right now. I would suggest to each of you, think about your team. Okay, what am I going to do? I'm going to have this in-service. I'm going to go over this and this and this and this and this. I'm going to show them all the forms. I'm going to give them the big picture of where this is going so that they aren't as lost as you feel. And you kind of give that, that sense of, I know where we're going and we can get there.
Okay.
But you think of each little piece, and in order to do that, you have to be operationalized for each one.
I'd like to make a quick comment about the process and outcome measures. As you're doing this, it helps me to imagine it. So imagine yourself walking in on that first day, like, what am I going to tell people? What am I going to do? And then the first time that I sit down to audit the charts, what will I be auditing and how will I do it? So I'm going to pull up this, I'm going to look at the list and I'm going to find out how do you find out who the patients are that you're supposed to be auditing? Like you decide I'm going to look at yesterday's patients. When I come in on Tuesdays, I'm going to look at Monday's patients, and this is the thing I'm going to check for and all of that. Also, think through your outcome and your processes, because they're all going to the same goal, but they should not be the exact same thing. So imagine yourself actually tracking, like actually looking at the chart, actually tracking this thing. Will your outcome run chart and your process run chart look identical because you're actually measuring the exact same thing? Really think through that, because you don't want to have a bunch of charts that look exactly the same because you weren't really measuring the thing you thought you were measuring.
And that's such a great statement, Nisa. If you think about when Nisa suggested, I think to Anne that she flip it, that she look at the 55% instead of the 45%. You want to make sure you're not having a run chart that looks at the 55% and another one that looks at the 45%. So that's the other reason. That's my last thing that I ask myself when I review your measures. Do they have an outcome and a process? Does the process lead to the outcome? Does the outcome lead to the aim? And then I look at all your operational definitions and I see if they're the same, because that's your double check. Oh gosh, this one's the same as this one, so you're really asking the same thing. And then the piece that I can't do for you is, am I measuring what is important to me? So if I'm trying to get all these people screened and appropriately treated for depression, diabetes, whatever the piece is, am I really measuring something that's going to be useful? Do I care how many staff members come to the meeting? If you have 4 staff members, you can measure it. It is a process measure. But is it going to give you some data that's useful to you? So if you have 50 people on your postpartum floor, it might be very useful that I've now gotten 30%, 50%, 75% of my staff trained, because that's going to seriously impact if they're working on doing what you want. If you have 4 people on your team, it's not saying you can't do it, but it may not yield you the information that you are hopefully looking for. So think about words that are understanding. It's good. It is an outcome, but maybe you can go a little further. Think about attendance at meetings. Is it important to you? Is it not important to you? Yeah, and that's why you operationalize. That's the last piece that I look at, because I will catch at least 50% of you, not catch in a bad way, but catch in myself, oh my gosh, I didn't realize it when you said it, but when you operationalize it, it's exactly the same thing. So that's a great point, Nisa. Okay, nobody else wants to go over measures. Going? All right. Okay, initial changes. questions about initial changes. So each of your ramps, you have your aim, your outcome, your process. Your measures are how you measure it. It's not what you're doing. So if you, and believe me, Nisa and I, Dr. Jollis, Dr. Thrower, we are so not perfect. And this is not easy stuff. So sometimes what happens is you tell me what you're going to do in your process measure is you're going to survey people. Sometimes that can be a process. If actually that process is real, if that survey is going to change each week what you're doing, it's going to be giving you information that is going to be useful in immediately changing things. But a survey, a tool, the implementation of a tool, a pre-audit checklist, shared decision-making tools, in meetings, those are your tests of change. That's what you're doing. Okay, so each of you, for each ramp, I'm going to have a team meeting. We're going to go over blah, 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 blah. I'm going to have my patient shared decision-making tool. That's what we're going to use. My process is the PHQ-9 that I'm going to be screening people with. And the referral is I have a case management log that I'm doing, or whatever, however that works for you. But that the tests of intervention are your tools, your things that you're doing. I think most of you did that. And you want to have, again, according to the ramps. So you have one for A, B, C, and D. You do not have to have a test of change for, oh, somebody balancing measure. Somebody balancing measure. Wait, let me see. Somebody had a balancing measure that wasn't really a balancing, and I don't remember who it was. What are the balancing measures? Tell me what those are. What is a balancing measure? Anybody?
Yeah, so a balancing measure is when you make changes in one part of your process and you unintentionally affect something else in a negative way.
Perfect. So if you think of the old-fashioned scale where you put something, you put it on and the other side goes whoop, that's what you're thinking of for your balancing measure, what you don't want to happen. So I can't remember who it was. Sorry, I didn't catch it quick enough. But somebody's balancing measure looked a little bit more like just something interesting they wanted to measure and not an actual balance, not a negative outcome. So a negative outcome would be if we were increasing breastfeeding, sorry, I'm a midwife, and we were increasing breastfeeding and a baby got dehydrated because this mama would not give this baby a bottle. We wouldn't want to go there, or we were screening people for diabetes and we didn't notice that their hypertension was, off the charts. Some other piece got let go.
I think of the balancing measure as the thing. I do a lot of process improvement in my own clinic, and I have for a long time. And so the balancing measure is the thing that everyone is complaining about behind my back. The balancing measure is when they're like, Nisa again with this, always wanting us to do things. And when they say like, well, if we don't prescribe antibiotics to these people, everyone's going to be coming in with pneumonia. The balancing measure is my way of saying, nope. We checked for that, and actually there were no more cases of pneumonia because we decreased the amount of antibiotics we're prescribing. Or actually another one, core measures. There's a core measure that midwives will be familiar with. It's a rate of primary C-section in the vertex position. It's a super annoying core measure because the way that it is stated implies that you should have zero, that zero should be the goal, right? And we know that's not true. If we did 0 C-sections, we would have some dead babies. That's a terrible idea. But there's no balancing measure. The core measures did not say, here's this balance of like, we're going to also track the number of babies that get admitted to the NICU or the number of negative outcomes. And if they had done that, I think that it would, when people read that core measure, they immediately say, well, we don't want our C-section rate to be that low. We're going to have all these NICU admissions. But the core measures are not tracking that. And if they were, it would allay those fears so that people could then say, oh, look, we had this low C-section rate and we did not get an increase in NICU admissions.
That's I love the way you said that. That's the things that all people are complaining about. That's so perfect. Perfect. Yeah, I don't remember who it was, but just look at your balancing measures. Barriers. Barriers are one of my bugaboos. Why do you want to think about barriers? Why do we even bother to ask you what the barriers are?
Maybe because if you're aware of the barriers, you can be already thinking about how to manage them.
Anticipation, right. And you need a barrier for how many ramps?
All of them.
I'm going to ask you that over and over and over. Every ramp. Yes, yes, absolutely perfect. If you are anticipating the barriers, so when you look at your predictions when we come to when you're actually implementing, what do I predict might be a problem? Good things and bad things. You know, what do I predict that this is going to go really well because this part the team is really interested in? Oh, this part I predict might not go so well because it's going to take time. So you're anticipating how you're going to mitigate that, how you're going to sell it, fix it, tweak it, whatever. And if you're anticipating a negative, do you want to wait a week to look at those numbers? No. You want to be looking at that and see if you're right. Yeah, I think this is going to be a tough one. Better watch this pretty closely. Okay? It's not all sunshine and roses. So a lot of it is. A lot of you, like Ann, are going to have a team that surprises you. But there's going to be some funny stumbles that you would never have anticipated. Those are okay, but anticipate as much as you can. Each ramp, each cycle, each tweak you make. Processes, I talked about that. Test of change, actions, tools. How do you sell it? Okay, I think make sure you have your references. Make sure they're in APA format. Nisa, I don't have anything else. You guys were super.
Yeah, you guys were really great. I think you've got a great idea of where you're headed already, so that's exciting. Just reach out to us, really. If as you're doing this, if something just doesn't seem like it's coming together, or it is easy to get lost in these words. I do it to myself, and I've been doing this a while. You know, where I suddenly can't, like, I just can't even see my way out. I can't even remember what's a process and what's an outcome, and I'll just like swirl myself into a little like tizzy of confusion. If it happens to you, reach out or put it down and look at it in an hour.
Yeah. You all did a great job. You know, you have wonderful projects. You are going to move the needle and make things better where your sites are. So, you know, we're so excited about what you're doing. And I just can't second what Nisa said enough. Please reach out to us if you need help.
I have a quick question, if I may.
Yep.
I was wondering, did you, during our buzz session, you shared with my buzz session that time your little diagram regarding this right here, if you can see.
Oh, yes, yes, yes.
I don't know if you shared it with the class, but this was very, 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 very instrumental. I don't know if any of the other students have seen this, but
guys, it's in the course. It's
right.
in the course. Do you want me to share it again?
Oh no, I mean I have printouts of it, but everywhere. But that, along with the measurement worksheet, that just helped cement it for me. So I really do value that. And then I guess the question I have is regarding the presentation today. Do you just want us to upload it into the Dropbox? For my case, I mean, may I make the changes to my project? Change my process before I submit it?
Your grade today is based on you participating.
All right.
So I don't really care what you put in there. I am not going to look at that and grade I'm not going to, actually, do we, Nisa? I don't think so. It's really participation.
I have not even looked at the rubric. I probably should have had that open while we were doing this, but I did not.
Okay.
I mean, you certainly can make the changes. And if you have questions and you want us to look at those one more time, but really this group conversation was what it's about. So it's not, I didn't mean to say that I don't care, but this is the chance for us to, hopefully by showing really good examples, the people who need that can pick up on that.
Okay.
But I'm glad that was helpful. The other thing that I would ask you all, since we're on this, and just a quick question, is we've struggled with why aren't people getting it? Why does it take so long and you feel so lost? Part of that is good. I mean, part of that is good chaos, because it does stir up your creative juices and making you think about it. What would be helpful to you? If you kind of see where this is going. What would be helpful to you? And Donald, when was that helpful to you? Oh, I shared it in the buzz session.
Well, I remember seeing it in the course, but when it didn't click until you pointed it out, per se. And then I went and I was like, wow, yes, it was good.
Okay. So I think part of what we're coming to is timing, that we have to do it over and over. Yeah. Okay. Any other thoughts on that? Anybody want to make a suggestion on how we can make it easier, better. I'm always interested.
Well, I think there was a large group of people who started this course this term and were sort of bombarded in the first week. They were bombarded in the first week with a ton of stuff that really they should have been doing before class started, that they had no idea that they should have done before class started. And so when you're kind of scrambling to get all of this stuff done that you really should have been doing weeks ahead, then you really delay how much you're getting into the class. I think they've solved that problem from what I've seen.
Are you talking about the CSAF and all that stuff?
Yeah. And I know for me, I thought I was going to have to drop the course. And so I was so busy for like the first 2 or 3 weeks with all of this pre-stuff that it took me forever to actually get into the content. And it was a horrible feeling.
Yeah, you cannot get behind in any of these classes. Well, I do thank you so much for sharing that, Caitlin. I think we have solved that problem. I hope. I mean, it's never solved, just like your QI is never done. But I think we've made a process change that will help that not to happen. I hope. You know, there'll always be some people who don't listen, but hopefully not the massive, because that might be right. I think, like Donald, you saw it, but you weren't able to absorb it yet. And then also, if you saw it, but you were doing 50 other things and worried about having to drop the course, that's certainly not going to put your centeredness where you need it, you know? Well, great. Thank you.
I will say that also, a part of the process of helping it click was reaching out to my clinical faculty, Dr. Thrower, and she kind of helped pull everything together for me with our little discussion. And she's probably sick of me by now, but hopefully not by the end of December.
Well, hopefully not. I don't think she's too sick of you because you've done a great job.
Thank you.
Beautiful, beautiful, and kudos to her. All right, folks, anything else? Nisa, any parting words that you want, words of wisdom?
No, I wish, I mean, I feel like there are probably still things, but I just, it's hard to know what they are.
Yeah. It's quick. It's very quick. I will just say to you, really, really, really work on getting this perfect for your final draft, because Caitlin, the same thing that you were just saying, if you are still working on this and trying to get it up to speed through the term break, which you need a term break, and then through that first week, if you're still struggling with your measures and your operational definitions, it's not a pretty start.
Yeah, I would definitely second that. Like when you look at this, at the draft that you just did, the second draft can't be a second draft. Like the next time you turn it in, it has to be perfect. And that's why we take off so many points here and there, why we have so many comments. And I think you get that draft back and you're like, oh my gosh, this is a disaster. It's not truly a disaster. It's just, this is not a paper that you can get a 90 on and be fine. Like, it has to be perfect after this, because if it's not perfect, if everything does not line up perfectly, you go to implement and things fall apart, and it's hard to recuperate then. It's hard for us to even notice in time to help, and there just isn't time. It doesn't work out. And for you to not succeed next semester because we didn't, or next term because we didn't catch something this term, would be terrible. So just every single comment, like address every single thing.
And reach out. If you are not sure, you're questioning, you're worried, if you have a gut sense that something's not right and you really at this point have no idea what you're doing, at this point you should have a fairly good idea where this road is leading you. You don't know the specifics, but you should feel the road that you're on. You may not see the light at the end of the tunnel, but you should know the road you're on. And if you don't, reach out now. Okay, I'm done. Thanks so much, everybody. It's been great having you. Make sure to drop your stuff in, and we'll look forward to your final papers.
Thank you so much.
Have a great day, everybody.
Guys, have a great day. Bye.
So, you know what I figured out?
What?
I used that little worksheet. I was just waiting till she was gone. I used that worksheet, and what I did.
Broadcast?
Huh? You can stop it. Yeah.